Good evening. I'm Henrietta Kotlas-Rosenberg. I'm the Director of Pediatric Radiology at Mount Sinai Medical Center in New York City, and I welcome you to Sono World. I'm happy to have the chance to talk to you this evening about urinary tract infection in the pediatric age range. Good evening. I'm happy to have the chance to speak with you about the workup of urinary tract infection in infants and children. The learning objectives are the following. When I'm done, you should be able to list the various causes of urinary tract infection in pediatric patients, to be able to recognize the imaging findings in upper and lower urinary tract infection, and to be aware of the controversies regarding appropriate algorithms for the workup of urinary tract infection in various age groups. Remember that pediatric patients are not small adults. We have to go out of our way to make our working area kid-friendly so that we will achieve cooperation. We have to cajole them, we have to entertain them. I highly suggest little Game Boys with their favorite little movies and games, DVDs that they can pick out to watch, toys to play with while they're waiting, books to have read to them while they're waiting and during the exams, and you can bribe them too with lollipops. Be patient, be understanding, and have lots of love, and you'll generally get the cooperation that you're looking for, given that this is such a painless modality. Urinary tract infection is a very common problem in the pediatric age range. Approximately 5% of children less than 6 years of age develop a urinary tract infection. The parents may notice that the child has fever. They may note that the urine is foul-smelling, that the baby or the child has become inexplicably irritable. A child who can express their symptomatology and discomfort may complain of abdominal and/or pelvic pain. They may complain of back pain. Parents may notice that the children are developing nausea and vomiting. They may notice in the children who are already potty trained that there is urgency and frequency and dysuria. They may note hematuria. Some children will develop incontinence and enuresis in the presence of a urinary tract infection, and yet others are failing to thrive, and as part of the workup, it is discovered that the child actually has chronic urinary tract infection. One should not even think about imaging a child with a urinary tract infection unless they've had a properly collected specimen. In an infant or a child who does not have urinary control yet, there must be a cathed specimen. If the child's urethra is not penetrable with a catheter, it may rarely be necessary to perform a suprapubic aspiration. In patients who do have urinary control, a clean catch midstream urine specimen is desired. In children who have a clean catch midstream, there has to be over 100,000 colony count to make the diagnosis of urinary tract infection. Those who have their specimen derived from catheterization have to have over a 10,000 colony count to diagnose urinary tract infection. And if it's a suprapubic tap, any bacteria is consistent with urinary tract infection. We don't want to subject the children to any imaging unless there is true documentation that they have a urinary tract infection. Early diagnosis and treatment is important to avoid renal damage. Some of the predisposing factors that we need to be aware of in the pediatric age range include the virulence of the infecting bacterial organism, and in particular P. fimbriae E. coli. This bug loves to adhere to the urothelial cells. These bacteria secrete endotoxins. When these endotoxins cross the mucosa to the muscle, they paralyze the muscle so that there is diminished ureteral peristalsis or none at all. When this happens, there is slow flow in the periphery of the ureters, and the adherent bacteria are not washed away. This leaves the child with the risk of ascent and reflux of bacteria from the lower urinary tract into the collecting systems as high as the kidneys. Some of the uncommon organisms that are predisposing are Klebsiella, Proteus, Pseudomonas. They are tending to be seen more in patients who have neurogenic bladder, and then Enterobacter. Other things to consider are including compromised host natural immune defenses, children who are on immunosuppression for various treatments, and when the feces are colonized by virulent bacteria. Now, most of the time we see urinary tract infection in little girls. It's easy to contaminate the introitus given the anatomy, but the other group that are boys that we see urinary tract infection in more often are the boys who are not circumcised. There is a 10 times the incidence of urinary tract infection in uncircumcised males compared to circumcised males. Other predisposing features include vesicoureteral reflux, obstructive processes in the urinary tract, and children who have difficulty in completely emptying their bladder during micturition. We have many choices in 2011 in terms of imaging modalities for the diagnosis and follow-up of urinary tract infection. Ultrasound and VCUG are the mainstay. There are hospitals that prefer to use nuclear VCUG, but in the current imaging armamentarium that we have, using the last image hold and very minimal fluoro and saving images instead of taking spot films, we can significantly reduce the radiation exposure with the voiding cystourethrogram. Nuclear renal scan is used when there is concern about scarring, function. Excretory urography is basically a thing of the past, and CT and MR are other options, but they are reserved for those patients in whom the ultrasound is inconclusive. So with the ultrasound, which has really become the modality of choice for screening the children with urinary tract infection, we are not dependent on renal function, and we're not using ionizing radiation. We can obtain a tremendous amount of information that serves to triage those patients who need additional imaging. We start with the bladder. Remember, little children are not going to cooperate to hold their bladder. They'll take one look at you and they'll decide it's time to pee, and there goes the bladder. So my recommendation is start with the bladder. If the baby does void spontaneously, you can always have the parent feed the baby while you're doing the upper tract part of the study, and then by the time you're done with the kidneys, chances are the bladder will start to fill again. So we're going to look at the capacity, we'll measure it, we'll look at the wall thickness, we'll look using the bladder as a sonic window at the distal ureters, and this is extremely important, not only to look at the size of the ureters, but to see whether or not there's a gaping ureterovesical junction that may suggest reflux. And then we can also use the bladder as a sonic window in children who have suspicion of a stone as an underlying cause of their urinary tract infection. And it really is a very nice, easy way to look at the distal ureters. Now, once the children have had the examination of the full bladder, they should void. Sometimes we have to encourage voiding by putting a little warm water on their feet, on their hands if they are still not potty trained. Sometimes we'll pour it right where they pee from, and then we get a post-void and check the kidneys as well as the bladder post-void. Now, so far as the kidneys, we're going to assess the size. It's very helpful in terms of serial sonograms to decide if the kidneys are growing or not, if they're scarring by looking at the contour, and looking at the echotexture, which we'll go into detail about soon. The collecting systems, we talked about the distal ureters, but it's important to look at the pelvic-calyceal systems and, whenever possible, to see the ureters. Normal ureters will not be able to be seen in their mid-portion because of all of the bowel and the bowel gas that are in the area where the ureters course through. But when they're dilated and they're tortuous, as you'll see, it's quite easy to see them with ultrasound. And then we can also look at the urethra so that we can determine if it looks like there is any abnormality, such as a diverticulum or possibly a posterior urethral valve or even a stone in the urethra. And we're always looking for a whole variety of anomalies, which we'll go into some detail about during this talk. Always include the bladder. As I mentioned before, it's a very important structure to look at because of the fact that it's going to give us a window to the distal ureters. But bear in mind that when the bladder is full, the pelvic-calyceal systems and the ureters will be better distended, and this shouldn't be mistaken for an abnormality. It's also important for the post-void films to show that the systems are decompressed. Is it always 100% that the fullness is just physiologic? No, it's not. But taken in the right context, I think that this information is helpful. So it's important to determine the bladder capacity, and there are two little equations that you can keep in mind as you're doing this to determine if the child has an appropriate capacity. If the baby is less than 1 year of age, you can take the baby's weight in kilos and multiply it by 7 to get the ml that one would expect for that age baby and its size particularly. If the child is over 1 year, then you take the child's age in years, add 2, and multiply it by 30, and that will give you a general range of where the bladder capacity should be in ml. You can also estimate the bladder capacity if your machine doesn't calculate the volume by basically taking the length times the depth times the width and divide it by 2. Just as a rule of thumb, a newborn baby will have a capacity of approximately 30 to 50 ml. A baby of a year of age will be about 100 ml. 5 years will be about 200. 10 years, approximately 300. And then over 10 years, it'll be similar to an adult, where it will be about 300 to 400. Always look at the bladder wall for its thickness, and it should be measured with the calipers. If the bladder is really well distended, the wall thickness should be less than or equal to 3 millimeters. If it's not distended, the wall thickness should be less than or equal to 5 millimeters. Examine the wall. Look for the trigone. And here we can see these almost looking like little froggy eyes that are coming up at the base of the bladder. And this is where we're going to look for the ureteral jets. It's not 100% if you see the jets that there is no partial obstruction, but it's important to demonstrate them to get as much information as we can. You can also look at the urethra. In the presence of a male, we're going to see a little prostate around the area on this sagittal view. We see this little very slender hypoechoic area bilaterally that looks like a little flat bow tie, and these are the seminal vesicles. In a little girl, you'll see something that many people, until they know that this is the urethra, look at it and think that this is a mass, but this is how a normal female urethra appears. This is just part of the area of the rectum, that's the uterus. And we can get images while the children are voiding if we have a question about the urethra. And here we can see that as the child voids, the urethra opens up as the urine is passing through. You can do that with a boy too. This is a little one who they had some concern about whether or not he had an obstruction in the region of the meatus of the urethra. And we had him in an upright position holding a urinal. And as he voided, we could see that the urethra becomes distended and that there is no obstruction here. And he had a great stream. My technologist will confirm that, as she got quite a bath during this procedure, so you have to be careful. Now, it's important, too, to determine if the urinary tract infection is involving the upper or the lower urinary tract. And that's why it's so important to try to assess the anatomy of the entire urinary tract to get clues. Now, the normal appearance of the kidneys in a newborn baby is different than what you're accustomed to seeing in the adults. In the newborn, there is accentuation of the corticomedullary differentiation. Here are the medullary pyramids that look quite black, and they are surrounded and interspersed between them by echogenic cortex. The cortex is isoechoic with the liver and the spleen in a very young baby who is full term. The increased echogenicity is due to a combination of a few things, including the cellularity of the tufts of the glomeruli is increased in the tiny baby. There are more loops of Henle in the cortex. And so over time, as the kidney grows, there will be more interstitial tissue, and the kidney ultimately will show decreased echogenicity in the cortex compared with the liver. Notice that there's very little fat in a newborn kidney. These are the renal sinus echoes. There's just a very fine, bright line around the kidney that represents some perinephric fat. As the kids get older, just as in adults in most situations, there will be an increase in the amount of adipose tissue around the renal sinuses as well as around the kidneys. Now, remember too that if it's a premature baby, because the kidney is even smaller, there will be increased echogenicity in the cortex compared to the adjacent liver and spleen. So our evaluation is going to include size, contour, parenchymal echogenicity. We're going to look for scarring, and we'll look at the collecting systems. Don't confuse the infant adrenal gland with the kidney. Know that the appearance of the adrenal is different than the kidney. First of all, the adrenal is going to flank the upper pole of the kidney, and it will straddle it. The cortex of the adrenal is rather hypoechoic, while the medullary structures look linear and appear quite echogenic. The adrenal gland can be up to half the size of the kidney in a newborn, and then very quickly in the next month will decrease in size. Some variants that you should be aware of as you look at the children: first of all, there may be fetal lobulation. You'll see little indentations as you get around each of these little mounds in which are the medullary pyramids. If these indentations are opposite the pyramid, then that would be scarring, but when you see it between, this is just a normal variation fetal lobulation. Dromedary hump is another thing that's often seen in the left kidney. It's probably due to the fact that the spleen is leaning on it, so that it is with a little bit of a different change in contour. But notice that there's normal pyramids coming around and into the hump of the kidney, and that's also a normal variation. Do not confuse the normal variation of the ranunculus with a scar. The ranunculus is a linear density that is very bright, that we see extending from the renal sinus out to the periphery of the kidney. This is also known as the junctional parenchymal defect. It is a little fibrofatty tissue that forms during embryological life as a means for the two renules to be fused to each other. And we see it much more easily in the right kidney. Remember, the size of the kidneys have to be evaluated, because part of the issue with urinary tract infection is that the kidneys could become scarred, or if they have chronic reflux, they may not be growing properly. So we're going to look at every age where the lower limits of normal are, what the mean is, and what the upper limits of normal, so that we can determine if the kidneys are normal for that particular child's body habitus, and also to determine if there's compensatory hypertrophy in children who have a solitary kidney or an opposite kidney that is not functioning well. Just bear in mind that the normal size for a newborn kidney is approximately 4 to 5 centimeters in a full-term baby. If you happen to be looking at a premature baby, you can take the gestational age and extrapolate it to centimeters. So if you have a baby who's 35 weeks gestational age, the size of the kidney is going to be approximately 35 millimeters or 3.5 centimeters. There are some disadvantages of ultrasound besides the operator dependence. Some people feel that there's decreased sensitivity for the detection of acute pyelonephritis, but we'll talk about how we can do that later on. Also, we can't quantitatively assess renal function, but if we don't see corticomedullary differentiation, that's kind of a red flag that we need to be concerned about renal function, assuming it's not an extremely obese child in whom the adipose tissue is masking our ability to be able to see the corticomedullary differentiation. We might miss small cortical scars, but we can look very carefully to try to avoid that. We may miss ureteral stones if they are in ureters that are not dilated, or they're not in the distal or very proximal part of a ureter. And if there is a fungal infection where there may be fungus balls, and we'll see an example of that later, in the absence of hydronephrosis, we may not be able to distinguish the tissue texture from the surrounding kidney. Well, I just want to take a minute to talk about the voiding cystourethrogram because it is an integral part of evaluating children who have urinary tract infection. Most of the time, they're very young babies that we'll do this in, and after 5 years of age, as we'll talk about later, we don't usually do a VCUG unless the ultrasound is abnormal. And what we're doing with this test is trying to determine if the child has vesicoureteral reflux and any type of avoiding abnormality, urethral abnormality as well. So we'll get a preliminary KUB if it's a very large patient, or we'll save a spot film, which is not really a film, but just saving the image from the screen. We'll do a sterile catheterization, or if it's a boy who has a tight phimosis and we can't pull back the foreskin to cleanse the external genitalia, we will cleanse it without pulling it back and then put the catheter where we believe the urethral opening is and do what's called a blind catheterization. We're going to measure the bladder capacity by determining how much contrast we actually put in. We're going to look at the bladder wall for thickness and contour, and we will obtain 2 cycles of filling and voiding films as we're looking for and grading vesicoureteral reflux when we find it. We'll look at the urethra, and then we'll have an estimation of a post-void residual. Some children show up for a VCUG who, instead of having total visibility to their urethra, little girls, we will see what are called labial adhesions. And in this situation, it's almost like a boy who's uncircumcised who has a tight phimosis because the adhesions are not allowing the bacteria and contamination to be able to be cleansed properly as the parents are taking care of the baby during diapering. And so in this situation, they may recommend Premarin cream until these adhesions are lysed, and then the child will come back for the VCUG. So as the bladder gets larger, we're looking to see whether or not there is vesicoureteral reflux during the filling phase, and then we're going to watch as the child voids and ultimately have a post-void to assess as well, and we'll look at the urethra. Not very much is going to be found in a female urethra, but in the boys, it's a very important part of the exam. We will, in the boys, get a set of images with the catheter in place and without the catheter in place as they're voiding, just to be sure that there are no urethral abnormalities that might have been masked by having the catheter in place, such as a valve or a stricture. Be aware in little girls that as they void, they can have reflux into the vagina in this supine position. And here you can see the urethra, the vagina, and here's the little cervical dimple from where the uterus is sitting. And here we see residual in the vagina. Now in the boys, I mentioned we're going to do the images with and without the catheter. And the voiding films are extremely important because some children will only reflux when they are voiding. Be aware that there could be, in a child who has reflux, ipsilateral obstruction that is coexisting, such as a ureteropelvic junction obstruction, a primary megaureter, or posterior urethral valve obstructing the bladder outlet. Many children who are found to have reflux are put on prophylactic low-dose antibiotic treatment, and there's a lot of controversy about this now in terms of whether it should be used routinely. With grade 1, docs are tending not to use it at this particular time, but it's very controversial, and you'll find physicians in different institutions following their own inclination. Reflux tends to occur in families, so screening of siblings is advised. It's thought that in little girls that there is an abnormal insertion of the distal ureter at the ureterovesical junction that is causing the reflux, and it's postulated that the ureter is inserting at a steeper angle so that there's less bladder musculature surrounding the ureter to function as a sphincter. And fortunately, as the girls grow, this abnormal angle of insertion diminishes, and spontaneous resolution of the reflux is likely to happen with time by the time the girls are about 5 years of age. So it has its natural history of resolution. However, in boys, it is not the same phenomenon due to the presence of the prostate gland. Secondary reflux can develop due to a diverticulum at the ureterovesical junction. Usually they are small, but they can be quite large, and they weaken the muscle around the insertion of the ureter so that the children can develop reflux. Other conditions that can predispose to reflux are neurogenic bladder and bladder sphincter dysenergy. The International Reflux Study classification is utilized to determine what the grade of reflux is in the children because of the fact that treatment decisions will be made based not only on the clinical findings, but on the degree of reflux and, of course, the appearance of the parenchyma of the kidneys. When there is reflux just into the ureter, that's grade 1. When the reflux goes all the way up into the entire collecting system, but there's no dilatation of the ureter or the calyces or the pelvis, that's grade 2. When there is mild to moderate dilatation of the ureter and the pelvis and slight calyceal blunting, that's grade 3. When there's moderate dilatation and tortuosity of the ureters and the calyces are moderately dilated with blunting of the fornices of the calyces, that's a grade 4. And with 5, there's marked tortuosity, extreme enlargement, and basically convex calyces with total loss of the papillary impressions. Just to see what that looks like on a VCUG, this is a grade 1 reflux. Here's another one where it refluxed into a normal-sized collecting system. If you look closely here, you'll see a little hutch diverticulum that predisposed to reflux on the other side. With grade 3, the collecting systems are more dilated. With 4, they're quite dilated. There's some loss of the papillary impressions. There's, in this particular case, intrarenal reflux. And with grade 5, we have severe tortuosity of the ureter with total blunting of the calyces. Now, we can look for evidence of reflux when we're doing our ultrasound. This particular baby has abnormal renal parenchyma. There's some diminished corticomedullary differentiation, and there is moderate enlargement of the collecting system, not only the intrarenal collecting system, but the ureter. And as we trace the ureter down to the ureterovesical junction, we see a gaping orifice. In the presence of a gaping orifice, it is very likely that the cause of the dilatation is due to vesicoureteral reflux, and that the reason the renal parenchyma does not look normal is because of a reflux nephropathy. Always look for changes in the size of the intrarenal collecting system. In this particular baby, we saw that there was a mild dilatation. Then right in front of our eyes, a few seconds later, it wasn't there anymore. But on the VCUG, it was obvious that there was grade 3 reflux. Look at the size of the kidneys. Make sure that the images are taken with the same scale. So if there is a discrepancy, we're going to be making measurements and assessing, such as in this child, where we see a smaller right kidney and it has loss of some of the CMJs. It looks like there's thinner parenchyma. And here on the opposite side, we see a perfectly normal looking kidney. Child did have right-sided vesicoureteral reflux of about a grade 4. Now, in terms of nuclear medicine, we can use that to determine if there is reflux. Some places feel that this is totally appropriate in girls because we're not really looking for urethral abnormalities and there's a lower radiation dose. But with a nucleocystography, since we are looking from a posterior view, the bladder, as it accumulates the radiopharmaceutical and is distending, can obscure the distal ureters, and so we could miss grade 1 vesicoureteral reflux. We also can't use nucleocystography to accurately grade reflux using the International Reflux Study criteria. We can't assess the bladder sphincter dysenergic problems. It is thought to be useful for screening siblings of a child with reflux, and there are some centers that are using ultrasound contrast agents to perform VCUG. Just to show you the nuclear study in this patient who has a small left kidney and a larger, more normal looking right kidney, looking from behind, we see that there is actually bilateral vesicoureteral reflux. As the bladder gets larger, the reflux gets worse, and as the child voids, the reflux is even much worse into this left kidney. Ultimately, when the bladder is empty, there is just a small residual left in the left kidney, but the right kidney has completely drained. Here's another example with ultrasound. We see thinning of the parenchyma. There's a little bit of loss of the CMJs. We can trace the ureter down. Looks a little bit almost like a GI signature, very similar appearance to the wall where we see the mucosa and then the muscular portion. We could see some peristalsis as we got more distally, and then ultimately showed the distal ureter here. This is the bladder, here's the rectum, and then during the VCUG filling phase, there was nothing that looked like reflux. However, once the child started voiding, we could see that there was massive vesicoureteral reflux all the way up into the kidney with blunting of the calyces consistent with a grade 5. Another one had normal renal parenchyma, but had moderate dilatation of the pelvic-calyceal system. There is blunting. The ureter, we see the proximal end is dilated. It's tortuous. We follow it down through the retroperitoneum, quite dilated, quite tortuous, and we could see to and fro peristalsis. We never could see a gaping ureterovesical junction, so we really weren't sure looking at this whether it was reflux or whether it was a UVJ, but then the VCUG confirmed that this was massive reflux into the left collecting system. Well, some of the treatments that are used, we've already talked about low-dose antibiotics. It's usually long-term suppressive medication till about 4 or 5 years, or until vesicoureteral reflux ceases. And many urologists have felt that this is very appropriate for low grade of reflux. When there is insufficient growth of the kidneys, when there is thinning of the kidneys, evidence of scarring, continued recurrent urinary tract infection, then thought is given to whether or not some type of anti-reflux surgery is appropriate, like reimplantation of the ureters. Also, there is the possibility of using endoscopic intravesical injection of a small amount of a collagen-like material into the bladder wall behind the submucosal ureteral tunnel that can serve to correct the problem of reflux. And the agent that is often used is called Deflux. The initial studies that were done at the Boston Children's Hospital published their results showing this gaping ureterovesical junction prior to the treatment with what was an autologous chondrocyte injection that tremendously decreased the size of the ureterovesical junction. This is what deflux looks like on an ultrasound. We see these very solid looking mounds of moderately echoic material. You have to be sure that you're not looking at clots, so turn the patient and make sure it's not moving. Turn on the Doppler to be sure that they're not masses. In Dr. Paltiel's article, they demonstrated that when the mound on follow-up appears to be bilobed, that can be a significant finding in terms of an indication of continued reflux. If the mound, as on this side, is round, then, and it's unilobed, it's more likely effective in correcting the reflux. Generally, over time, the volume of the mounds decreased, and there are situations at times where the treatment with a deflux can induce hydroureteronephrosis. It's uncommon, and it's usually self-limited. Some of the upper urinary tract anomalies that we need to be concerned about include ureteropelvic junction obstruction, ureteral duplication that may be complete, incomplete, may have an associated obstructing ureterocele. Some children develop ureteral obstruction because of primary megaureta due to an atresia or a kink. And then there are children with ureterovesical junction obstruction. So let's look at a few examples. Here's a chance to see an IVP, an almost extinct study at this time, where we see the difference between the right kidney that's normal after Lasix emptying, and here's the obstruction on the left. With ultrasound, we see the large renal pelvis, which is the most medial structure, connecting to the dilated calyces. There is some thinning of the parenchyma around this, but there is some preservation of the corticomedullary differentiation. Remember to look at the bladder first, because looking at the upper tract, we really don't know whether there is dilatation of the distal ureter. So if the ultrasound shows hydronephrosis and the VCUG is normal, then one has to assess the renal function and may need to assess glomerular filtration with a DTPA study, or possibly tubular excretion using Lasix washout to demonstrate the quantification of renal function with a diuretic renogram. In the normal situation, we're going to see after the Lasix a very rapid washout. When there's obstruction, we will not see that phenomenon, but then there are some intermediate ones that are indeterminate because of poor function or because of dilution of the radiopharmaceutical. Sometimes we need multimodality imaging for problem solving. This kidney looked like it had a giant cystic structure in the lower pole, the little fullness of the upper pole collecting system. Here we see that there's some contrast in this area where the cyst was that is deviating the left upper pole ureter. These are a little bit dilated. Nuclear medicine showed the normal upper pole. There was some pre-Lasix radiopharmaceutical seen in the region of the cyst, and then after Lasix we see that there is an obstruction to this portion of the kidney. So this patient had a duplicated collecting system with a ureteropelvic junction obstruction involving the lower pole moiety. MR is a very time-consuming study, and unless there is an inconclusive ultrasound, we generally reserve this modality for children in whom we cannot provide enough information for accurate therapeutic decision making, but it certainly is an option when there are questions. Duplex kidneys are seen in a small % of patients, and as long as they have no symptoms and they have no dilatation of the collecting systems, we're not concerned. As we can see with this voiding cystourethrogram, it's possible that there can be reflux into the lower pole of the duplex collecting system, in this particular configuration known as a drooping lily appearance, because of the fact that there is another part of the kidney here that is not refluxing but taking up space. Another example with ultrasound, normal upper pole, we see a dilated collecting system in the lower pole, very decreased depth to the renal parenchyma surrounding this patient who turned out to have grade 5 reflux. We can see this in the same orientation as the VCUG. There are times when we're going to be able to show with the ultrasound that in addition to the dilatation of the upper pole moiety, we'll follow the ureter. It will be dilated and terminate as an ectopic ureterocele at the base of the bladder. Ectopic ureteroceles are seen in various places. Remember, the upper pole ureter is inserting more medially and inferiorly than where the trigone would ordinarily have the ureter insert into, so that in little girls it could be in the bladder, it could be in the bladder neck, it could be in the vagina. And in fact, if there isn't a ureterocele and the ureter is actually draining urine, these children who have the ureter inserting into the vagina may present with consistently wet diapers and incontinence. In boys, it's not a problem, even if it's inserting into the posterior urethra, because of the fact that it's proximal to the external sphincter. Another one masquerades as a renal cyst. Renal cysts are very rare in children. If we follow the ureter all the way down into the region behind the bladder, we see that it terminates within the bladder as a large ureterocele. Notice the fullness of the lower pole moiety. This is due to reflux. Sometimes the ureteroceles will evert, and we can see in this one on the initial VCUG that there's a filling defect. As the bladder gets bigger, the defect gets smaller and ultimately is everting out of the bladder. Here's where the patient voided and it gets larger again. Primary megaureters can be seen. This is usually associated with an adynamic distal segment of the ureter. It's more common in boys than girls. It's frequently bilateral. Lasix, pre and post, can be very helpful in deciding whether or not there is a significant obstruction that requires surgery. Many of these will spontaneously regress. In terms of ureterovesical junction obstruction, if we do a VCU and we don't see reflux, but we see an indentation in the area where the ureter should be, we need to trace that ureter very carefully. Here's the sagittal view. Here's the kidney. Obviously no corticomedullary differentiation consistent with a nephropathy. There's dilatation of the pelvic-calyceal system, marked dilatation and tortuosity of the ureter, which terminates as a very narrow pointed structure consistent with ureterovesical junction obstruction. Now, lower tract anomalies include things like neurogenic bladder, bladder and urethral diverticula, bladder and urethral fistula, such as we may see in patients with imperforate anus, posterior, anterior urethral valves, and phimosis. Posterior urethral valves have been shown to be significant in causing obstructive uropathies and renal dysplasia because of the obstruction. There may be bladder wall thickening and trabeculation. There can be dilatation of the posterior urethra and a utricle, and there may be vesicoureteral reflux. These children can present with a urinary tract infection, but they may also have a lower abdominal mass because of the distended bladder. They may have a poor urinary stream, and these boys may be incontinent. They may have a mass because of a urinoma. If there are microfractures in the fornices of the calyces, they can present with urinary ascites as babies. Rarely will the bladder perforate. Typically in these boys, we're going to see a thick-walled, trabeculated bladder, and if we angle appropriately, we will see the dilatation of the posterior urethra. It's helpful if we can get them to void a little bit. We can also look at the perineum and the base of the penis to see the urethra using that approach as well. And then the VCUG is essential to document that there is a dilated, obstructed posterior urethra secondary to the valve. There's also diverticula coming off the bladder. Typically, these patients will have bilateral, severe dilatation and tortuosity of their ureters with variable degree reflux. This is a 5. There's even intrarenal reflux, very elongated bladder with diverticula, and the dilated posterior urethra. This patient also had renal dysplasia associated with it, where there is bright echogenicity seen through most of the parenchyma. Some valves are not really significant in causing obstruction, like this type 3, which is in the mid part of the posterior urethra and is essentially a web. We may be able to see the cyst-like structure that is present in patients with an anterior urethral valve, which basically leads to the same type of obstructive and reflux findings as we may see with posterior urethral valve if it's large enough. Remember that babies with phimosis, the uncircumcised boys who can accumulate a huge amount of contrast in the foreskin during the voiding phase. Pyelonephrosis can be considered when looking at a sonogram where there is echogenic material within the collecting system in the presence of a bacterial or fungal infection. This is a patient with renal dysplasia with a posterior urethral valve and ended up with fever and urosepsis in the presence of pyelonephrosis. Other things can look like this, including protein and blood, although blood is usually much brighter initially. This little preemie baby, you can see the hyperechoic renal parenchyma, has no corticomedullary differentiation, has hydro, and here's a little fungus ball that had been noted with the ultrasound and confirmed with culture. Here's another patient who had this mass in the region of the pelvis, next to the rectum, behind the bladder. Going sagittal on this, we see that it's really a dilated tubular structure with a fluid debris level. As we traced it superiorly, we could see the fluid debris level and then this huge structure that is connected to what looks like the normal part of the kidney. So this was basically an ectopic ureterocele with a duplicated collecting system with a totally normal mid and lower part of the kidney, but the patient had pyelonephrosis and had urosepsis. This was easily drained through a cystoscope. Stones can be associated with urinary tract infection, and it's important with the ultrasound to look at the entire urinary tract. CT in the pediatric age range is reserved for patients with negative sonograms and high clinical suspicion of calculi. But there's really no reason to put a child who is not obese through a CT. We can look for dilatation of the upper tracts, the ureters. Here's the distal ureter, slightly dilated, and here's a little stone sitting right above the ureterovesical junction. Sometimes when we do CT, we will get information that's helpful in terms of showing inflammatory changes in the perinephric space. If there are stones in the ureters, there can be a rind of soft tissue attenuation in the periureteral space, the rim sign, due to edema in the ureteral wall, and often we'll be able to use our axial coronal and sagittals to confirm hydroureteronephrosis. Here's a patient who ended up with a CT scan. He was a little bit chubby and had a stone right at the ureterovesical junction. Well, there's no reason to follow this with CT. We can use ultrasound very nicely as our baseline, show the dilatation of the intrarenal collecting system, this little bugger right at the distal end of the ureter, and look not only for the shadowing of the stone, but the twinkle artifact with color Doppler. Don't forget to look at the urethra. This little boy had a urinary tract infection and complained that he couldn't void, that he had terrible pain and really couldn't void. We looked at his penis to try to see what it was that was causing his problem, and sure enough, there's a stone that's shadowing, sitting right in the fossa navicularis, in the glands of the penis. Now with pyelonephritis, children have a variety of presenting features depending upon how old they are. The babies will often be irritable, have fever. Older children may have flank pain. They may have nausea and vomiting along with their fever. Although the findings can be more challenging in the ultrasound evaluation of acute pyelonephritis, there are several things that we can look for that can help us come to the conclusion as to whether or not the kidneys are abnormal. Sometimes we do not see any abnormalities, but in a florid pyelonephritis, we may see renomegaly. We may see decrease in the corticomedullary differentiation. There may be focal parenchymal abnormalities. Usually they're increased echogenicity. In the region where there is pyelonephritis, there can be decreased color Doppler flow. And it's been shown that when there is thickening of the wall of the renal collecting system, that can be indicative of pyelonephritis as well. So let's look at a few images. This is a kidney that was swollen. There's areas that look like they are hazy, increased echogenicity. Looking at this one, we see more of a focal area of increased echogenicity that correlated well with a DMSA study. This is the so-called focal lobar nephronia. It's important to follow this, not only to look for scarring with follow-up ultrasound about a month later, but one cannot absolutely exclude a tumor. A hematoma could have the same appearance. And obviously, if it's pyelo, that will go away over time, hopefully not with scarring in the area. If it's a hematoma, that will ultimately liquefy, may also have some scarring, but obviously if it's a tumor, it's not going to diminish over time. Here's an example of a patient who has normal corticomedullary differentiation in the upper portion of the kidney, the mid portion, and then in the lower pole there's a more focal area of increased echogenicity. Color Doppler shows that there really is very little flow down here, confirming that there is a focal area of pyelonephritis. This is from the article by Robin showing that there can be some thickening of the collecting system in the presence of acute pyelo. Scarring, duplex system, in this particular child shows normal parenchyma. Follow-up showed that there was scarring around the lower pole. Another example, the lower pole had nice rounding, but in the upper pole there were areas of scarring. Now, as I said before, CT and MR are usually not necessary, but are reserved for complicated urinary tract infection where we can't show the abnormality with ultrasound. The findings that we can see very easily with these modalities are renomegaly. We may see focal areas of decreased contrast enhancement. We may see perinephric stranding, renal abscesses, perinephric abscess, easier to see with these modalities, and perinephric collections, but those are usually pretty easy to see with ultrasound. Here's an example of a large perinephric collection in this patient with a urinary tract infection. The abscess on CT, we can see after contrast enhancement, is totally without enhancement. Pyelo, if we look closely, we can see areas that look like there are multiple areas of decreased enhancement. This is very typical for pyelonephritis, although you can't absolutely exclude masses such as one may see with lymphoma. Perinephric collections, when they are echolucent, can be very easy to see, but if you look at this kidney, there is actually a rind of moderately echoic material around the perinephric fat here. And with CT, it's a lot easier to see. Cystitis. Most females who have urinary tract infection have cystitis as their underlying abnormality. They may present because they have urgency, frequency, dysuria, hematuria. They may complain of lower abdominal or pelvic pain. They may have a new onset of urinary incontinence if they're already potty trained, and the parents may notice that the urine has a strong foul odor. With cystitis, sonographically we may not see any abnormality, but there are children in whom we see thickening of the bladder wall. It may be diffuse, it may be focal, and it seems to be more common in the presence of a hemorrhagic cystitis due to viral etiologies. And in fact, with viral cystitis, the bladder wall may have characteristics that are suggestive of rhabdomyosarcoma, but the history differentiates cystitis from tumor, with the ultrasound findings and symptoms resolving within 2 weeks in the presence of viral cystitis. Here's an example of a patient who has lobulation and thickening of most of the bladder wall laterally and posteriorly. And there are many phases of cystitis. This happens to be a patient who was treated with Cytoxan, who had increased vascularity in the bladder wall in addition to thickening and septation within the bladder. In this patient, there is a polypoid protrusion not only from the anterior wall but posteriorly. And in this example, we see bullous cystitis where there are cystic changes in this area of bladder wall thickening. This patient had circumferential thickening and irregularity of the bladder wall, and these all mimic rhabdomyosarcoma. All of these examples have shown, but in fact turned out to be viral cystitis. This looks like a large mass in the bladder. As the bladder distended, we see that it's merely bladder wall thickening. We don't expect a tumor to change its size or configuration. 2 weeks later, this was totally resolved. Other conditions that can mimic cystitis include neurogenic bladder, urachal diverticula, bladder wall diverticula, focal bladder wall thickening due to an indwelling catheter, patients with prostatitis, and of course, tumor. This is a patient with a neurogenic bladder. Despite the fact that we asked her to try to empty her bladder, she never could achieve successful emptying. Here are the little diverticula around the bladder in this patient with spina bifida. Big diverticulum in this patient that can certainly have static urine within it. We see the neck connecting to the bladder. Now, many babies present with a prenatal sonographic report of hydro. They don't have a urinary tract infection when they come in, and it's really important to delay the sonogram whenever possible to the 10th day of life when the babies are already well hydrated and have good glomerular filtration. If you think that the parents will have enough sense to come back, it's always appropriate not to do the study while the baby is still in the hospital in the first couple of days of life when they are relatively dehydrated. Since there really isn't proof that there's any benefit of prophylactic antibiotic therapy, we can use serial sonography to determine if and when VCUG is appropriate. Always be respectful of the cancer risk of radiation exposure in children, and instruct the parents regarding the importance of urinalysis and urine culture when their children have unexplained fevers. So the recommendations are really quite controversial. Where I practice, babies who are newborn to 6 months who present with a first febrile urinary tract infection will get an ultrasound and a VCUG. Within the rest of the first year of life, over 6 months of age, a first febrile urinary tract infection, I would have to say that many of these babies get an ultrasound and a VCUG, but will definitely get a VCUG if the ultrasound is abnormal. With children who come in with cystitis, Generally, we don't do a VCUG unless the ultrasound is abnormal. And if they have recurrent urinary tract infection, we don't do a VCUG if the ultrasound is normal. Nuclear medicine studies are reserved for children in whom we think there may be obstruction, so they'll get a diuretic urinogram, and CT and MR when the sonography is inconclusive or when it's necessary for surgical planning. Remember, if you look for trouble, you're going to find it, and there really is no proof of benefit of demonstrating low to moderate grade vesicoureteral reflux with a VCUG, as there's no proof of benefit from prophylactic therapy. VCUGs terrify parents and young children, and unless it's absolutely indicated, it shouldn't be done. Now, it used to be we were getting VCUGs annually in the children who had urinary tract infection where reflux was demonstrated. Now it's being done at less frequent intervals, and really when it's done is guided by how the child is doing clinically. As to when to do the sonogram, that is also dictated by the clinical and laboratory findings. And urine cultures are extremely important in monitoring children who have vesicoureteral reflux to determine if they've had a recurrent infection. So thank you for the opportunity to share my experience with you on urinary tract infection in the pediatric age range. Good night.